Premature ovarian insufficiency is characterized by deficient ovarian sex hormones and decreased ovarian reserve, which together lead to an accelerated reduction in ovarian function and an early onset of menopause. Premature ovarian insufficiency is the loss of normal ovarian function before the age of 40 years, a condition that affects approximately 1% of women under 40 years old and 0.1% of women under 30 years old. It is biochemically characterized by amenorrhea with hypoestrogenic and hypergonadotropic (FSH) conditions and loss of fertility. It is further characterized by deficient ovarian sex hormones and decreased ovarian follicles that accelerate the onset of menopause. This condition often results in subfertility or infertility, as it is associated with hypoestrogenism, which causes menstrual irregularities and pregnancy failures. The decrease in estrogen secretion also causes a myriad of menopausal symptoms, such as hot flashes, night sweats, and insomnia. In addition, long-term consequences of premature loss of ovarian function increase the lifetime risk of skeletal fragility and cardiovascular and neurocognitive disorders. The causes of premature ovarian insufficiency are diverse and can be classified into several categories. Some cases of premature ovarian failure are linked to genetic abnormalities, such as Turner syndrome, the partial or complete absence of one X chromosome or Fragile X syndrome. Mutations in specific genes that regulate ovarian function can lead to the premature failure of the ovaries. In some women, the immune system mistakenly attacks ovarian tissue, disrupting its function. Premature ovarian insufficiency has been associated with autoimmune thyroid disorders and Addison's disease. Cancer treatments, including chemotherapy and radiation therapy, can damage ovarian tissue, leading to premature ovarian failure. Similarly, surgical removal of the ovaries or other pelvic surgeries may result in reduced ovarian activity. Exposure to toxins, such as cigarette smoke, industrial chemicals, or specific medications, has been linked to ovarian insufficiency. Additionally, lifestyle factors, including stress and poor nutrition, might contribute to the condition. Premature ovarian insufficiency is diagnosed when a woman presents amenorrhea before 40 years of age with an elevated serum level of the pituitary gonadotropin follicle-stimulating hormone, FSH, with low levels of estradiol, E2. Serum levels of FSH and E2 are measured on at least 2 separate occasions, with more than 4 weeks of interval. And patients that present with continuously elevated FSH levels, greater than 25 IUL, are diagnosed with premature ovarian failure. Spontaneous pregnancies are extremely rare in patients with premature ovarian insufficiency. Women experiencing premature ovarian insufficiency have menstrual irregularities that hinder their fertility. Some patients with idiopathic premature ovarian insufficiency present an intermittent ovarian function, and hence their chance of conceiving spontaneously and having an uneventful pregnancy course is approximately 5%. Premature ovarian insufficiency is different from menopause in that ovarian insufficiency may not be permanent. Among the 25% of premature ovarian insufficiency patients who can ovulate, only 5–10% can conceive. Premature ovarian insufficiency can be reversed depending on whether amenorrhea is primary or secondary. Primary amenorrhea is more serious than secondary amenorrhea, making reversal easier in the latter. Laboratory test results for FSH, estradiol, and inhibin B can predict the chance of primary ovarian insufficiency reversal. Oocyte donation is the recommended treatment for infertility due to primary ovarian insufficiency, as it has been proven to achieve a 70–80% successful pregnancy rate. Immature egg cell donation is also indicated for women born with Turner syndrome, the partial or complete absence of one X chromosome, but only after undergoing cardiovascular control, as they are prone to cardiovascular mortality during pregnancy. Fertility preservation strategies, such as the cryopreservation of oocytes, ovarian tissues, and embryos, are suitable alternatives. Gonadal function can also be protected by surgically changing the position of the ovaries out of the pelvis. Ovarian cryopreservation is another option for women who have hormone-sensitive malignancies and for those who will undergo hematopoietic stem cell transplantation for aplastic anemia, sickle cell anemia, and thalassemia major. Furthermore, a new approach known as in vitro activation, IVA, of dominant follicles has gained relevance in the treatment of infertility. In vitro activation disrupts the Hippo signaling pathway and stimulates phosphatidylinositol 3 kinase, PI3K, to activate dominant primordial follicles in patients with primary ovarian insufficiency. Careful counseling of women with premature ovarian insufficiency to provide emotional support is crucial, since premature ovarian insufficiency has been associated with physiological distress. It is important to minimize the sequelae of hypogonadism through continuous evaluation and medical treatment. Low levels of serum estrogen may cause low bone mass and be a predisposing factor for coronary heart disease. Appropriate physiological estrogen, progestin therapy, is regarded as the conventional management of premature ovarian insufficiency, as it ameliorates the health complications resulting from this condition, such as menopause-associated symptoms, loss of bone mineral density, fractures, and dry eye syndrome. Hormone replacement therapy, HRT, involves the prescription of hormones to replace those that normally would be present but are deficient. HRTs include the administration of bioidentical and non-bioidentical estrogens and progestins, such as norgestrel and progesterone, as well as compounding for women that require multiple hormones. Estrogen deficiency is the primary ovarian hormone deficiency in women with premature ovarian insufficiency. Therefore, unless estrogen-based hormone therapy is contraindicated, estrogen treatment is required to replace the depleted estrogen. Ongoing research into premature ovarian insufficiency holds promise for improved diagnostic techniques and novel therapies. From advancements in genetic studies to innovations in reproductive medicine, the future offers hope for individuals affected by this condition. Primary ovarian insufficiency is a complex and multifaceted condition that demands attention across medical, emotional, and societal domains. By fostering awareness, research, and compassionate care, we can empower women with premature ovarian insufficiency to lead fulfilling lives despite the challenges they face.